through it.
Good evening. On behalf of CSI Karnataka and other organizations, I heartily welcome one and all for this World Health Day virtual program. All delegates who have joined virtually from whichever place to learn from the esteemed faculty. I welcome our state CSI office bearers, Dr. Vivekanand President, Dr. Ramurthy Pingi Secretary, Dr. Manjunath Treasurer, and all KCSI family members, and all the senior faculty of Karnataka CSI and Bangalore chapter members and postgraduates, and Dr. Nadesh, Executive Body Member, South Zone Central CSI, and all the Executive Body Members of KCSI. On this occasion, I welcome our guest of honor, Nadoza Professor Dr. P.S. Shankar, present Professor Emeritus RGHS Bangalore, who has held many positions in the past, BC Roy awardee with 5 different university doctorate awardee, and received Nadoja from Hampi University, a teacher of teachers and teacher par excellence. Senior most CSI member, delivered prestigious Umrani Banerjee National CSI Oration in 1987. His contribution to teaching and association is exuberant. He has translated medicine into Kannada language with innumerable publications, received many awards. He is a medical encyclopedia. His CV runs for hours to read. I also welcome our own faculty, Dr. Jayant Antani from Pune, who has joined. I welcome our chief guest of today's function, Dr. Vijay Bang, Senior Interventional Cardiologist, Leelavati Hospital, Mumbai, and President-elect, National CSI. A great academician par excellence with many publications, national and internationally, received many awards, a great teacher and a researcher, a great name in the field of cardiology in the country. I also welcome today's guest speaker, Dr. V.S. Prakash, Chief Cardiologist and Head of the Department of Cardiology, MS Ramaya Medical College, Bangalore, a great teacher with many publications to his credit. I welcome our today's Chief Moderator and our own senior most faculty, Professor Dr. Nagaraj Desai, excellent teacher, researcher, scholar, held many positions in the past with many publications to his credit, a great name in teaching the students, teacher par excellence. I also welcome our today's panelist, Dr. Ullas Pandurangi from Madras Medical Mission, Chennai, who heads the Department of Electrophysiology. It is always a pleasure to be associated with Triple M, as last time we had a wonderful program with Dr. Ajit Mullasari also. Dr. Ullas held many positions in past, like Vice President, Indian Rhythm Society, Founder President of Tamil Nadu Electrophysiological Council, Past President, Indian Society of Electrocardiology, recipient of the Dr. D.P. Basu Award 2002 and the Young Cardiologist Award of CSI Conference 1997. On this occasion, I salute the COVID-19 healthcare workers for rendering their untired service to COVID-19 patients in spite of so many hurdles in the past, anticipating third wave surge coming down. Let us not waste the time by reading their CV profile, which runs in pages. Let us utilize time by hearing and exchange of knowledge with them in their respective specialty. As I can see, more than 100 delegates who are registered from many states in making a national event. The advantage of virtual meeting, which COVID-19 pandemic has taught a new normal life, that speaks how powerful the speakers are there in the specialty. Now we have a formal virtual inauguration.
Shubham Kurutvam Kalyanam Arogyam Dhanasampada. Shubham Kurutvam Kalyanam Arogyam Dhanasampada. Shatru Buddhi Vinashaya Deepajyotir Namostute. Deepajyotir Namostute. Shubham Kurutvam Kalyanam Arogyam Dhanasampada.
ಕೇಳ್ತಾ ಇಲ್ಲ ಏನೋ ಅವ್ರು ಹೇಳೋದು ಕೇಳ್ತಾ ಇಲ್ಲ ಅವ್ರು ಹೇಳೋದು.
Now I request Dr. P. A. Shankar to address the gatherings.
Dr. Vijay Bang, Dr. Prakash, Dr. Nagaraj, Dr. Ullas, Dr. Vivekanand, Dr. Rammurthy, Dr. Manjunath, Dr. Sangram, members of CSI and the participants. I am happy to be part of the program on the approach and management of Simco. I am honored that 3 of my students are taking part in this particular program. World Health Day is celebrated on 7th April each year with an aim to promote the benefits of good health and well-being worldwide. It marks the anniversary of the founding of the World Health Organization in 1948, with an aim to improve the understanding of the universal health coverage and the importance of primary health care, and to make universal health care a reality for everyone. Since 1950, WHO selects a theme each year based on the suggestions of the member governments, giving an opportunity to the member states to focus attention on the important public health issues that affect the world community. This year's theme, Our Planet and Our Health. By selecting this theme, WHO has tried to create awareness among people that health is a human right and everyone should have access to the right care at the right time and the right place in the community. Through the universal health coverage, every person should be able to get healthcare facilities without any financial difficulties. The aim is to promotion of health, prevention of disease, and when disease strikes, its diagnosis, treatment, and rehabilitation. All these facilities must be available at a manageable cost. Persons below poverty line are put into great hardships. Universal healthcare tries to provide them quality healthcare at a reasonable cost. Healthcare workers play an important role by providing the policymakers about the plight of the persons in the rural areas, slum dwellers, people living in hilly and forest areas in getting quality health care. By ensuring universal health coverage, the target of the sustainable development goal can be achieved. There is a need to measure the universal health coverage in the country by determining the proportion of the population in the country who have an access to the quality health care, and also to proportion of people spending a lot of money to regain their health. Through various state governments are putting their effort by spending large sums of money to improve the healthcare facilities, and it is encountering difficulties to provide free service on a sustainable basis. Comprehensive health insurance is one measure to ensure the financial protection for people facing the health hazard. Today, CSI has organized a program on Simco, and I wish the program all success. Thank you.
Thank you, sir, for your kind words of wisdom. Now I request State CSI President Dr. Vivekanand to say a few words. Dr. Vivekanand. Kindly unmute.
Good evening, everyone. It gives me great pleasure to invite you all to this year's first virtual meeting of Karnataka State CSI Chapter. CSI Karnataka Chapter was started in 2002. Over the last 20 years, promotion of academic activities has been one of the primary responsibility of the society. It is also involved in research activities and various public health initiatives. I am happy to inform you that KCSI has successfully registered under Section 80G of Income Tax Act, which provides benefits to the donor of an NGO, and also Section 12A, which will assist an NGO to get an organization. Future of our association rests on increased participation of our young
network issues.
Yeah.
So we can.
Dr. Vivekanand, you are not audible.
Network is gone.
Yeah. So now,
He's back. He's back.
yeah.
Yes, sir. Can you hear me, sir?
Yeah, go ahead.
we
Go ahead.
can, yeah.
Yes, sir. So today we have an eminent faculty to discuss about syncope. It is a common clinical problem which needs to be dealt by practitioners of all specialties, including electrophysiologists. I hope everyone will enjoy the next 1 hour session. Thank you.
Thank you. Now I request Dr. Ramurthy Bungi, Secretary, kindly say a few words to. Kindly unmute, sir. Unmute. Still not unmuted.
Now it's unmuted, I think.
Yeah, right.
Thank you very much, Dr. Biradar. My sincere regards to my professor, Dr. Shankar, Dr. Nagaraj Desai, and my other colleagues, friends, and also our president of the Karnataka CSI. Just now he spoke. We have started this academic program with Dr. Biradar's batting only. We hope that we are going to do continuously like this in the coming months, and we try to provide you as much as a good feast as well as a learning platform for many of us and also the younger generation of that. In this regards, I have already sent you a letter also for to promote the young persons to do the research work. Being, we are office bearers hardly for a year time, we may be able to encourage them for a short-term programs. Please kindly all of you encourage such an activity. I hope that I want to see that the more and more people are getting aware of that. And equally, my point is to, in this regard, is that I have been talking this repeatedly, Dr. Vivekanand and even Dr. Biradar, that this umbrella should unfold throughout the state. It should not be only one part of Bangalore or part of the Karnataka. Hopefully with these few sentences, I don't want to take much time. Let us go ahead with our scientific program. Thank you very much.
Thank you, sir. Now I request our chief guest of today's function, Dr. Vijay Bang, for your inaugural address, sir. Over to you.
Thank you very much for inviting me to be chief guest. It's an honor to be here with all of you. And my regards to Dr. P. Shankar and all the senior members here present on the dais. Very respectfully, I say, I'm really honored and pleased to be here with all of you. Now on World Health Day, we have a good program which is being organized by you, and it is befitting for the World Health Day because we as a cardiologist can look after only the heart part and look after well. So there are two challenges in the society that we are facing at the moment. One is out of hospital cardiac arrest and many young patients dying due to unawareness of what to do if you have a person having a syncope on the road. So we need a proper infrastructure, and that infrastructure should be available across India. That is the minimum responsibility of all cardiac organizations in the country. And in that regard, we should collectively do some sincere effort so that we spread awareness of on out of hospital cardiac arrest. Second is our PAMI rate in STEMI is pathetic, 5%, whereas in Western world it is 95%. And if we can achieve, at least now the cath lab structure is existing in district levels, all district levels across India. So at least urban STEMI should get PAMI. Many schemes are available. Funding is no issue in those cases. All the government schemes can fund this STEMI program very easily without any issues. Only thing, lack of awareness, total lack of awareness, particularly the cooperation of physician, the primary physician, is of paramount importance. He must be educated. If you have a STEMI, please send it to cath lab capable center if it is available for you and get the PAMI done within 90 minutes. That will reduce lot of mortality, that will reduce heart failure, and that will make our society a better society to live. This is twofold major responsibility as a cardiologist we have. And we all should think about it jointly and collectively without any bias and without any credit to anybody. And we should try to do collectively and make sure that people at large, community at large is benefited from these two perspectives that I have spoken this evening. We all know that the health, the nutrition, the nutrition comes from food. The food quality, food quality, particularly the soil health, is gone down because of urbanization, environmental damage due to lack of proper ecosystem development. So many things have been done which are very wrong. And COVID is a result of those wrongdoing by the human being. So that gave the planet to get healing touch in these 2 years. And it required that, because if the planet is healthy, then we can be healthy, because our food comes from our planet. What we eat is a fast food, which is called as American Standard Diet, SAD. So we should change to a plant-based diet, totally. See, COVID obviously came from the animal virus. So we have to understand this part. The animals are also equally important for this planet to be healthy. So we have a responsibility to, look into ourselves and do something for the society, which is through our organization. One person or two person or maybe 10, 100 people cannot do it, but organizations certainly can effectively impart all this activity. And for that, we should do some collective job. And at least one Karnataka society can try that. We start with Karnataka society. And it's not a big job. All we have to do is spread awareness. Spread awareness. That's all about do few things that I have spoken to you. See, there is a paradigm shift in the risk factors. Earlier, smoking was major risk factor. Now, smoking has come down due to awareness. Let me tell you this. World over, smoking has come down. But the diet is westernized, fast food. So it led to maximum obesity, hypertension, and diabetes. So these are the newer risk factors which is causing microvascular disease. In addition to having a epicardial coronary disease, we have coronary microvascular dysfunction, very predominantly coming up, especially in women. If you go to see, there is an article in Circulation 2020, which shows the mortality trend in the world, global mortality trend. From 1980 to 2010, the mortality trend due to cardiovascular disease were coming down. But from 2010 onwards, the mortality trend of cardiovascular disease increasing. It has reached an alarming level. We know that we have done excellent job in improving pharmacological intervention with various research and various advances. We have done a catheter intervention. We have done a surgical intervention. We have improved the life. We have improved the cardiovascular mortality. But now it is again rising because of change in the epidemiological risk factors, paradigm shift. So we have to be aware of this, that we have to change our diet. So third thing that I recommend strongly, that we should have a complete comprehensive diet which should be plant-based. So this is what the message I thought I can give on this day of World Health Day to a great society like Karnataka Cardiac Society, CSI, and expect you to give me a lead for next year, show me some credibility on these two aspects, out of hospital cardiac arrest, what network has been done, and the PAMI rate in at least Karnataka should become 50%, if not 95%. This is what I just want to convey, and I wish you all a very successful academic event that you are going to have. And good luck. And you kept a very apt program, which is syncope. So that makes it very relevant on first that I spoke out of hospital cardiac arrest. Now, another thing we can, predict the cardiac arrest in patient is, only if we do Holter for 24 hours, it can manifest 2% of the event. But if you do it for a month and few months, it can go up to 15%, from 2% to 15%. So it's a 700% more. So we have to think in that direction. And now that there is a patch available, you all must have learnt about this patch available for Holter monitoring. In a patient who's got near syncope or some fainting attack somewhere, we can do, or there is a family history. We can do this for a long time, Now there are several devices available which can be, subcutaneously implanted in the body, which can give you monitoring for 6 months. And then you can non-invasively take the data out by integration of the device. So I think, thank you very much. And we'll meet again. Of course, this year CSI is going to be in person. So we'll love to see you, all of you there in Chennai. And I'll try to do maximum for the scientific program. Thank you very much.
Thank you, sir, for sharing your valuable time and your kind words of wisdom. Your points are well taken. We'll follow accordingly. Now we move on to the scientific session. I request Dr. V.S. Prakash, sir, to deliver his talk on topic approach and management of syncope. I request our moderator, Professor Dr. Nagaraj Desai, to take over for further proceedings, as Dr. V.S. Prakash is already introduced. Over to you, Dr. Nagaraj Desai, sir.
Friends, it is a great to have all of you together here in this virtual platform. Thanks to Dr. Biradar, and thanks to my professors, Dr. P. Shankar and Dr. Antani. And of course, good friends like Prakash and Ulas together will make a great combination for us to learn from these experts as to what is to be done for a patient who has history of so-called syncope. Now, as I see the various guidelines from European Society and American Society, American College of Cardiology, American Heart Association, and their comparisons and the knowledge, the wisdom that comes out of these guidelines will definitely play a part in formulating our own approach. But importantly, the clinical approach we learned from our own, wise professors that they are, Dr. Prakash and Dr. Ulas. As I have directly worked with Dr. Prakash for more than 1.5 decades, I know him as a clinician at the bedside, and I cannot say more than this, except to say that he will bring the best out of his practice when he teaches his students and his colleagues. And I want to learn from him today as to, is syncope, is it true or is it false? In what percentage of patients we can reach the proper diagnosis? And in what percentage of patients can we reliably treat them forever? And what is the prognosis of syncope? With these few words, just a kind of a starter for the audience to think about, the questions that they would like to pose to the speakers and to the other kind of expert faculty like Dr. Ulas. May I request Dr. Prakash to get started with his presentation. Sorry about this, little longer introduction, just to make sure that the audience will get ready with their questions. So Dr. Prakash, please.
Thank you, sir. Thank you for that. I'm greatly honored and humbled by your statements, and with humility, I would probably put forth my little bit of wisdom, whatever is there that I would like to share. And I'm honestly honored to be among such an august audience, such senior faculty, and it's a great honor for me. And without much ado, I would probably share my screen and then start off with so my screen is seen, sir?
Yes, sir. Yes, sir.
Yeah,
It's visible? Yeah,
yes.
thank you. I'll go to slideshow and then. So let's start with a case scenario. 25-year-old female medical student, syncopal events since childhood, usually prodromes, now increased incidence, and physical examination was normal. So approach to syncope. Syncope is a Greek word to say interrupt, and syncope means sudden transient loss of consciousness and postural tone with spontaneous recovery. And the loss of consciousness usually occurs within 10 seconds of hypoperfusion of the reticular activating system in the midbrain. So when we approach a patient with transient loss of consciousness, we say it's syncope, but we know there are a lot of differential diagnoses. And once you evaluate and you think it's not syncope, you automatically go into a different evaluation course. But if you think it's syncope, yes, you need to look at the history, physical examination, ECG, and then based on the certainty of the syncope you treat. If not, you again evaluate and risk assess. So that's the broad algorithm in which we try and approach a patient who's had transient loss of consciousness. We have various mimics. I would not want to waste time about talking about the mimics, because we know outright we can differentiate a syncope, hopefully, from the other mimics and try and narrow down today's talk to syncope. One important differential diagnosis is seizure, which I think many of us have this problem. So we need to definitely differentiate seizure from syncope. It's not very difficult because seizure is a prolonged event, lasts longer, and you have a lot of loss of involuntary tone and fecal and urinary. Fecal incontinence is something which is not seen in syncope and rare, unlike seizure where it's usually associated. You may have myoclonic jerks in syncope, but you'll have tonic-clonic movements in seizures. So, and as I said, it lasts longer, and there's a post-ictal phase where patient is drowsy and so on and so forth. But many a times, we will have a problem differentiating these two important events. Let's again come back to syncope. What is the impact of syncope? Impact of syncope is profound. Anxiety, altered in the daily activities, restricted driving, change of employment could be quite a big issue. So syncope is not something that we can ignore. It needs to be taken care of. In fact, if you look at quite a few studies, the ER, 3% of ER admissions are due to syncope, and 1% of hospital admissions are due to syncope. So that's the kind of profoundness with which this important problem presents. Causes of syncope, again, varied, but one thing is very clear, 30 to 50% of syncope are neurocardiogenic, or they are known as vascular syncope. Rarely is it cerebrovascular. Cerebrovascular, if you look at this, is just about 1%. And if you realize, most of the times, patients are referred to the neurologist when somebody comes with transient loss of consciousness. I think that's a futile attempt. But luckily, our neurologists are very smart. They refer back, asking various evaluations like a Holter, Hutt, and so on and so forth, realizing that it's not their territory. So we understand that most of the syncopes are due to vascular syncope, and next important is cardiac syncope, which Dr. Vijay Bang did address to, which could be a fatal, near fatal event unless it is approached properly and checkmate. So we understand these are the two important causes for syncope, and we need to differentiate these two and try and treat them accordingly. Another important thing is many of times, though proper evaluation is being done, anytime between 20 to 25% of patients, you may not have a proper diagnosis. So that's the limitation we have today with a patient who comes with transient loss of consciousness. So as I said, physical examination is very important. We need to understand whether this man has some structural heart disease, so on and so forth, and which will be able to pick up these things by physical examination. This patient, this medical student, had a regular pulse, blood pressure was quite normal, there was no postural drop, cardiovascular system was normal, and no carotid fluid. So what is the risk stratification? So now this patient is coming to ER, and you need to know what is to be done with this patient. Do you need to admit the patient, occupy a hospital bed, or can you discharge the patient from the ER itself? How do you go now? So we have various risk scores for this. I think one of them, quite popular, is the Canadian syncope risk score, where you're looking at a point evaluation, and then you look at various aspects. Classical vasovagal symptoms, is the history of heart disease, blood pressure, is there a drop, and then elevated troponin levels, ECG changes, and so on and so forth, based on which you give a scoring. You call it as low risk, medium risk, high risk, and very high risk. So once you go into the high and very high risk, obviously this patient needs to be hospitalized. And we have various ways of trying to evaluate the scoring. We have low risk and we have high risk, major and minor. I won't go into the details of this, but we know that we have this scoring system by which we can clearly, in the ER itself, differentiate somebody who's low risk versus high risk or moderate risk. This patient's ECG was normal, and so looking at again the ECG changes being normal, we know there are some major high risk ECG changes like Mobitz type 2 or third degree AV block, sinus bradycardia, bundle branch block, VT, so on and so forth, or a Brugada syndrome, which will clearly place them into a high risk, and definitely they need further evaluation. So as I said, once you have a patient coming in with transient loss of consciousness, you clearly place them in one of these categories and thereby decide which direction he takes. Low risk, he can be discharged from the ER itself. High risk definitely needs further evaluation, needs to be admitted. And if he's neither a high nor low risk, he needs to go into the syncope outpatient clinic and further be evaluated, trying to understand what could be the cause for syncope in this patient. So as I said, vascular cause forms predominant cause for etiology for syncope, anywhere between 30 to 50%. This could be reflex mediated or orthostatic. Reflex mediated is what our classical vasovagal syncope is, what this medical student had, and you have those classical features of blurred vision, sweating, turning pale, etc., which can easily be identified by the history itself. And we know this is a complex syndrome where you have an afferent pathway and an efferent pathway working at the medulla oblongata level, and whereby you have peripheral vasodilatation, peripheral pooling, and then rapid sympathetic activity initially working on an empty ventricle, and then subsequently there is profound activation of the parasympathetic system, bringing about bradycardia and hypotension, cerebral hypoperfusion, and loss of consciousness. How do we evaluate such a patient? Somebody who's been having recurrent episodes, 1 episode, 2 episodes, it's okay. You know it's vasovagal. But say a patient has been having recurrent episodes, we need to go with further evaluation. I think the classical test that we do in this kind of a patient is the tilt table test. Tilt table test will help us differentiate between common, faint, and malignant vasovagal syncope. Malignant vasovagal syncope comes without much of syndrome, and this could result in injury even head injury, and it could be dangerous. So this is what we need to understand, especially when we are dealing with an elderly patient. So tilt tables recommend one thing is to try and discern the diagnosis, whether it's orthostatic hypotension, it's POTS syndrome, or even pseudo psychogenic pseudo syncope. All these could be differentiated by tilt table. Not only that, you can do tilt training and make the patient understand that this is what is happening to you when you tilt him and you become symptomatic. So that becomes an important way of managing patients with vasovagal syncope. And the positivity rate could vary from unaided versus trying to use nitroglycerine or using isoproterenol, where you can try and increase the sensitivity of this test, especially depending on the indication, and try and get the best out of tilt table test. This is what we do. We tilt to about 60 to 70 degrees and then keep them in that position, and then check their blood pressure and heartbeat as we are doing the tilt table test, and record simultaneously their hemodynamic changes. You see in this patient who had a pause of anywhere between 4.8 seconds, and then also a drop in the blood pressure, which is a type 1 response, is a mixed response. So you can have two types of response, or three types rather. One is the vasodepressor, where you have only blood pressure drop. There is not much of bradycardia, or the heart rate does not drop more than 40, or the pauses are less than 3 seconds. Or you can have a classical cardioinhibitory type, either a type 2A or a type 2B, where you have an asystole or bradycardia, the pauses are more than 3 seconds, or the heart rate is less than 40 and lasts for about 10 seconds. Or a combined, which is a type 1 response, you have both drop in the blood pressure as also a drop in the heart rate. This is the classical type 1 response of the VASIS type 1. This is a patient, 50-year-old, without cardiovascular disease, frequent syncopes and pre-syncopes over the last years. If you look at this patient going through the tilt table test, you see that once you tilt the patient, you start seeing absolutely asystole during that period without much of a drop in the blood pressure, classically the type 2A response. And this, again, another patient with an asystole lasting for about 29 seconds on tilting the patient to 60 degrees. A mixed response, the VASIS type 1, as I said, where you have a vasodepressor or a cardioinhibitory response, where you have both the things are correct. You can further, if in case your tilt is not coming to be positive, you can use nitroglycerine, where the sensitivity becomes a little more without compromising much of the specificity, and you can definitely get more out of your tilt table test. This was a patient with cardioinhibitory response on nitroglycerine, had a long pause, 16-second pause. 45-year-old patient with syncope, 4 times, Holter monitoring was normal, did a heart test, and there was a 5.2-second pause. We have various variants of neurocardiogenic syncope. The most classical variant is the carotid sinus hypersensitivity, which you start seeing in the elderly. And we have also the micturition syncope, cough syncope, swallow syncope, and so on and so forth. These are all neuroreflex syncopes. This was a 72-year-old male without cardiovascular disease, frequent falls and turning the head or neck to the right over the years. So probably we are looking at carotid sinus syncope. So this is, again, you give a carotid sinus massage for 5 seconds, unilateral side, and continue blood pressure ECG recording. And this patient had a flat line for easily more than 5 seconds. Another patient, 72-year-old, right carotid massage into 3 seconds and long 6.8 pause. So obviously these are the patients who would probably benefit by a pacemaker. We'll look into the management. So we call carotid sinus massage as being positive if there's a ventricular pause lasting for more than 3 seconds, a pause, or a fall in the systolic blood pressure of more than 50 millimeters, which is obviously a combined response. And the recommendation here is definitely somebody more than 40 years of age and who's been having these episodes of syncope. You can definitely go ahead with a carotid sinus massage. This was a mixed response, a vasodepressor response with carotid sinus syncope. This was another 64-year-old man with swallow syncope. Again, neuro-mediated syncope. Another important thing that we are noticing now with bariatric surgery is there's a lot of autonomic dysfunction, and a lot of these patients come with autonomic dysfunction, with POTS, with orthostatic hypotension, and even some of them have neurally mediated vasovagal syncope, sometimes requiring intervention. So this is another important thing that we need to bear in mind, especially with the increased number of bariatric surgery that we're likely to see in the future. So now, how do you manage syncope? I'm confining initially to neurally mediated syncope. We have various guidelines starting from 2001 to 2018. 17 was the ACCHA, 2018 was the ESC, and 2019 we had a comparison of these two guidelines side by side to understand which would kind of be more aggressive. So with regard to reflex syncope, one thing we need to understand is its education. We need to educate the patient. It's a class 1 indication, and you need to make them understand to change their lifestyle. And that is the most important thing, which has a class 1 indication. Younger people, especially, you need to stress on this, and you can do the tilt training. Rarely with a class 2 indication, you can try midodrine or glucocortisone. You can train them for counter pressure maneuvers. And in case we are still not able to succeed, you can try and look at an ILR guided management, especially in case you're not able to understand why this patient is still being symptomatic with syncope. And in case the patient is on hypotensive drugs, you need to obviously stop them. Elderly people may be dominant cardioinhibitory type. There may be an indication for putting a pacemaker, which again carries only a class 2A or a class 2B indication. We can't be aggressive and put in a pacemaker for all patients. So it's very important with vasovagal syncope, education, and then salt and fluid intake, counter pressure measures, and rarely you try and use drugs or pacemaker. So pacemaker has a class, if you compare the ACC versus the ESC, ESC gives a class 2A indication for patients who are having syncope and aged more than 40 years, and asystole for more than 3 seconds, or a sinus arrest for more than 6 seconds. In that condition, they say there's a class 2A indication for putting in a pacemaker, whereas ACC, AHA gives a class 2B indication. So we understand that VVS syncope, pacemakers carry only a class 2A or a 2B indication. How about hypersensitive carotid? Again, if you're looking at this, probably this moves up a little, it gets a class 2A indication in elderly people who are having classically the cardioinhibitory, where you have a long pause, cardiac asystole, so on and so forth. In these kind of patients, where you can definitely indicate probably putting in a pacemaker when they're recurrent we're having a burden by a recurrent syncope, but again a class 2A. What is the benefit that we get by putting in a pacemaker? If you're looking at somebody who's having only bradycardia and no hypotension, high efficacy, 5% recurrence, less than 5% recurrence rates. But if you have somebody who has a mixed response, a type 1 versus type, low efficacy because this man continues to have hypotensive episodes and the recurrence rates are much higher. So we need to be very careful when we advocate a pacemaker in such a scenario. Now moving on from that, we move to another 50-year-old female, 6 episodes of fainting in the last 4 months, especially on getting up from sleep. Momentary loss of consciousness, and she had a head injury also. Malaise and fatigability, she's taking adequate fluids on examination, no pallor, blood pressures are normal, JVP is okay, cardiovascular examination was clean. How do we approach this case? Standing BP, if you check, was 88/67. So we have what is known as orthostatic hypotension. What is a risk stratification? Again, we have to look at the Canadian risk stratification. Here, very clearly, you know there is a systolic blood pressure drop of more than 2, and she's had probably a cardiac syncope. So her category would go into the medium. So we need further evaluation. So very important, this is one thing most of us miss, is checking blood pressure in standing. So when somebody comes with probably episodes of transient loss of consciousness on standing, I think the most important thing we need to know, especially in the elderly, is the orthostatic hypotension. Syncope due to orthostatic hypotension, it has a class 1 indication for checking in standing blood pressure. When do we say orthostatic hypotension? When the systolic blood pressure drops by more than 20 millimeters of mercury, diastolic more than 10 millimeters of mercury, or a decrease in the systolic blood pressure less than 90 millimeters that produces symptoms. So this is what is orthostatic hypotension. So in this patient, do we recommend an echocardiography? Clinically, everything was normal, but somehow something was suspicious. This lady says she's been taking adequate fluids, and that means that is one of the ways of treating orthostatic hypotension. So what could be the reason? Let's look at her echo. Echo is indicated class 1 when you have a suspicion of a structural heart disease, though clinical evaluation might not have picked up something. What did we pick up in her case? She had an atrial myxoma. So that is what was causing orthostatic hypotension in this lady. Apart, you obviously need to take care of the myxoma, but how do you treat orthostatic hypotension? Again, the class 1 recommendation is acute water ingestion, maintain adequate fluid intake, and drugs, midodrine, droxidopa, fludrocortisone, counter-regulatory measures, all these carry a class 2A to class 2B indication. And obviously, if patients are on medications which could cause orthostatic hypotension, we need to withdraw. Now moving on to another case, 63-year-old male, one episode of syncope while watching TV, no chest pain, no prodromal, and no residual weakness or deficits. Who should be the first consultant to be called? Neurophysician, which we normally do, or the ENT, or the general physician, cardiology, or the EP. If you look at choosing appropriate investigations in a patient with syncope, ECG, frequently obtained, and helps determine etiology of syncope in 3.5% of patients. Telemetry in 4.7% of patients. Whereas HCT in just 0.53% of patients, you could make out what was the cause for syncope. You're wasting your time doing a CT brain. What about orthostatic hypotension? Checking the blood pressure and standing. 15%, you could diagnose the cause for syncope, which you're missing. You're not checking at all in the ER. So that's the importance of evaluating a patient and understanding how to approach a patient rather than just refer everybody to the neurosurgeon for neurophysician for evaluation. This patient, known case of CAD, status post CABG, EF was 32%. He was seen in the clinic a week later. Examination was unremarkable, ECG, old interval MI, 2 PVCs. We asked for a 24-hour Holter. This is what was seen on his Holter. So immediately, patient was, luckily, it was an aborted SCD. He underwent an AICD implantation. So we understand when we're dealing with syncope, if you look at this graph, patients with the cardiac cause for syncope have the worst prognosis. So it's very, very important that we discern and diagnose cardiac cause of syncope in patients who are coming with transient loss of consciousness and not to miss them. Especially in the elderly, we need to be very, very careful, but that doesn't mean the young are not affected by cardiac problems. So syncope, use the ECG. If you see this ECG very clearly, patient has a underlying bifascicular block. And if you see P waves are marching all over, so patient has an advanced AV block and an underlying bifascicular block. So he has a complete heart block. We understand ECG should be able to give us why this man is having syncope. So syncope will tell you about MI, about EV blocks, and about VT, and WPW, prolonged QT, so on and so forth. So ECG is a very, very useful tool to diagnose syncope right in the ER. 20-year-old young male presented to the ED with syncope. 3 episodes, syncope 3 months back, and both the times happened while running on the treadmill. Otherwise fit, athletic, blood pressure has been normal. Look at the ECG. He has epsilon wave noted in the chest leads, and look at the T wave inversions from V1 to V4, V5. So we are dealing with suspiciously, probably, I'm sure. So obviously this patient had abnormal ECG, and we were thinking that it's cardiac syncope. He goes into the high risk category. So I think more than the Canadian way of evaluation syncope, there's this very simple OSIL score for syncope, which gives you just 4 points. Age more than 65, cardiovascular disease and clinical history, syncope without prodrome, and abnormal ECG. So you have a scoring system. And with the increase in the number of scores, you start realizing that with just 1 score, 0.8, with 2 scores, 19.6, and with 3 scores, 34.7, is the 12-month all-cause mortality. And if there are 4 scores, 57.1% is the 12-month mortality. So you're clearly picking up those cardiac cases which need to be approached and treated. So this study very clearly said those who had high risk scores by the OSIL with syncope, most of them had an event, either required pacemaker on an ICD, or some of them died. So that's the importance of trying to evaluate by the simple scoring system. So this patient automatically is a high risk. We did his echo. This is what we saw in the echo. Classical ARVD or ARVC. 14-year-old boy, 3 episodes of exercise-induced syncope. His EKG was normal, resting EKG. So we said no, as Professor Vijay Barg said, we should do an extended Holter monitoring or an event monitoring. We put him on an ILR, and this is how either an event recorder or an ILR could work. This is the ILR. Your various companies coming out with this subcutaneous insertion of ILR. This patient underwent the same thing. And there's a class 1 indication, especially in patients with recurrent episodes and when we're not sure about the origin of the syncope. And this is what we got on the ILR. You see multiple episodes of polymorphic VT. So what this man had was probably a CPVT with the cardiorenin receptor mutation. And if you look at his mother also had Holter monitoring, which showed a similar kind of episodes. Something else that you can pick up with this event recorder or the ILR is you can pick up these episodes of long pauses, which you may not pick up on a Holter monitoring or a routine ECG. So bradyarrhythmias and advanced AV blocks could be picked up even by this long-term recordings. So this is what I'm trying to show you. Is there a role for electrophysiological testing? Probably in patients with suspected arrhythmia. And especially there's a class 1 indication with ESC when there's a previous myocardial infarction or scar-related indications, and you know that probably this man could be having scar-related VT and resulting in syncope. This was another patient who came to us baseline with chest pain. And if you see, he's having ST elevation in the chest leads. So we thought probably it's an anti-wall MI, took him up for an angio, coronaries were normal. Wondering what was happening, took him up for a propionamide infusion, and this is what we find. Classical Brugada. And this is just an anecdotal patient who had syncope following the Pfizer vaccination, unmasking a Brugada syndrome. So EP study, classically, as I said, class 1 indication would be in patients with syncope and previous MI and suspected scar-related VT, VF episodes. So this is where probably you do an EP study. And in patients who are suspected to have bundle branch block, a prolonged HV interval, which again would indicate probably that this has conduction system disease and needs to undergo a pacemaker. So sinus node dysfunction, a disturbance of AV conduction, SVTs, and VT. But the yield of EP study for syncope is very low. This patient, 75-year-old woman with syncope, 2 episodes, Holter monitoring was normal, just showed sinus rates of 35 to 80, no pauses. Took him up for a sinus node dysfunction, a sinus node recovery time study. And if you see, there's a long pause post atrial pacing. Sinus node recovery time was quite prolonged. This patient had a prolonged HV interval, 110. Normally, upper limit is 55 and 110, obviously telling you there's an intrahisian conduction problem and patient needs a pacemaker who has had LOCs. So cardiogenic shock, yes, definitely pacing would be indicated if you have sinus node disease, 2nd degree or 3rd degree AV block, and so on and so forth, which would carry a class 1 indication for a pacemaker. Patients who have SVTs, especially when the rate is more than 200, they can have hypotension, and that can also result in syncope. This patient had AV and RT induced and ablation done. Patient was relieved of her problem. So SVT could also be another cause for syncope. WPW with pre-excited AFib can be another reason for a syncope, which needs to be picked up and treated accordingly. And once you have that, there's a class 1 indication for catheter ablation. And if you're suspecting ventricular tachycardia in a patient with reduced LV function, it carries a class 1 indication for ICD. Hypertrophic cardiomyopathy with syncope or arrhythmogenic ARVD, which I had shown, again carries hypertrophic cardiomyopathy carries a class 1 indication, whereas ICD in arrhythmogenic RV dysplasia has a class 2 indication. This patient, MI ejection fraction 32, and had sudden LOC, took him up for an EP study, induced VT, and again required an ICD implantation. So as I said, defibrillator has a class 1 indication for patients who have aborted SCD and LV function of less than 35% and who are in heart failure after more than 3 months of optimal medical treatment. Again, there's a class 2A indication for patients with LQTS and also in patients who've had a Brugada syndrome. Rare situations, I think I'll skip this. Just the last case scenario before I close the talk. 43-year-old female with Apla syndrome. She has had associated weakness of the left hand lasting for at least 6 hours post-syncopal attack. And she had pre-syncope affecting her quality of life. She had frequent abortions due to Apla syndrome, mild pallor, no significant cardiac signs. Blood pressure on the left side recorded 90, whereas on the right side it was 110. So what are we looking at? She had a classical subclavian steal syndrome because she had a stenosis of the subclavian artery proximal to the left vertebral artery, and she was having, every time she would move her arm, exercise her arm, she would develop syncope. Very, very rare cause of syncope in somebody with a subclavian steal. Thank you for your patient listening. And I would request now the
Prakash, it was a wonderful talk. I really kind of overwhelmed by the case scenarios that you discussed so rapidly, almost like a rapid fire session. So many.
Sir, I was scared of you, sir. I know you are a stickler for time. 35 minutes, I didn't want to overshoot.
Not at all.
I'm honestly telling you.
In fact, it was a wonderful talk. I'm sure I'm sure in case, I request Dr. Ulas, in case he has to add something which you have not added, this is the time to request Dr. Ulas to come in. And, your Dr. Prakash can also respond. After that, we will open the chat box. Until then, we'll wait. Dr. Ulas, please.
So, as you said, this was a compilation of syncopal cases belonging to various categories. I think he tried to convince, like, how do we approach? I would like to say the way, I kind of approach this syncopal in the day-to-day cases. I think while it's a challenge to diagnose the cause of syncope in someone who has a normal clinical examination and a normal ECG and a normal echo, meaning you need to be doing this good clinical examination and a normal ECG and a normal echo. And if there is no family history, I think that's going to be a benign case, even if it is recurrent, as long as there is no injury, irrespective of the age. You got to have a normal ECG, a normal echo, no family history, even if it is recurrent, and no injury. I think we could go slow there. However, if there's anybody who has a syncope and there's a history of an injury associated with it, and if the history or there is an evidence to suggest that there's a structural heart disease or there is an evidence of a coronary artery disease in the past, we should simply think this is malignant. And that is a ventricular tachyarrhythmia to begin with, or maybe a little benign, it could be bradyarrhythmia. If this is the way we focus upon, I think we'll bring in quick answer to the problem. The head-up tilt testing has its issues. Taking a great length of the history, it is supposedly to be, is a good way, but those people with the structural heart disease are also vulnerable for vasovagal syncope. That particular episode in a patient with a myocardial infarction in the past with a lower ejection fraction, if you've taken a good history, that particular episode could be vasovagal. But we should remember that he is now at risk for sudden death because of a malignant arrhythmia. So I think Prakash told correctly. How do we approach to begin with? I think it is ECG and not a CT scan. And a clinical examination, and then see whether there's a structural heart disease. And if there's a family history. This, I think, is kind of my approach, which is less of a theory and more of a practical utility.
Let's get back to Dr. Prakash. Does he have any additional information in response to Dr. Ulas when he was pointing out what is his clinical approach as he walks into the ward in his office?
So I think that's what I also was trying to mention, the same thing. Whatever Dr. Ulas said is you definitely need to look at the family history, the baseline ECG, and the clinical evaluation and the history. History, I think, becomes the most important tool to clearly differentiate neurally mediated syncope from other causes of syncope. I think history is forthcoming. It differentiates from seizure. It puts the bracket into the syncopal diagnosis. And once we have made a diagnosis of syncope, automatically differentiating the high risk from the moderate risk to the low risk is, I think, based on these few parameters. One is the clinical history. We know it's vasovagal syncope, so automatically its scoring system goes into negative. And then we have the ECG, which will give us a good idea, and also the family history, as he said. And if there is structural heart disease, but I think one thing I would be careful about in trying to evaluate a patient with a structural heart disease, though, as Dr. Ulas said, we can have episodes of vasovagal syncope in those patients, but I would be very careful not to miss a more malignant cause for syncope. So I would probably depend on an ILR there to really understand that we are not dealing with some dangerous kind of syncope, rather than dismiss it off a vasovagal or a neurally mediated syncope.
Excellent. That I think one has to be kind of a pragmatic in his approach when we find a structural heart disease, unless it is a milder varieties of structural heart disease. For example, a mild aortic stenosis and moderate aortic stenosis, and a patient has syncope. We don't have to kind of triturate the patient to get some more data out of him. Now, I just wanted to pose one question. Dr. Gururaj Kulkarni has raised a hand. He has a question, I think, and I don't know. Where is his question? I can't see that. Kindly post his question, please. Let me ask you a question. A patient has a syncope and a left ventricular dysfunction. How do you go about it? Would you like to go through a Holter or ELR or ILR or EP and then on to ICD? Or would you like to go ahead with ICD? Both of you can respond to this. Dr. Ullas first.
Probably Dr. Ullas.
All right. So I think Prakash already mentioned, when you're talking about the LV dysfunction, let's now talk about the etiology of the LV dysfunction. The patient with the LV ejection fraction less than 35%, if it is past myocardial infarction, he doesn't have to wait for a syncope. You can even think about prophylactic ICD. Now let's talk about more than 35%, and now he has a syncope. If there's a myocardial infarction history, unless put otherwise, that is because of a scar-related ventricular tachycardia. That's how we should be going about. Now, there are two things. One, you can waste time in putting in an ELR or ILR, or you can take him to the lab. If you have a documented ventricular tachycardia, which is monomorphic during a short period of an observation of 24 hours or say a week of time, you can take. But if there's an absence of a monomorphic or whatever the kind of a tachycardia in that period of observation, if you did not find, I don't think he should waste time in the ILR. He qualifies according to the guidelines as a class 1 indication for EP study. Well, there is a question here. You do not subject any patient for an EP study as long as he's not willing to get an ICD implanted. You can't just take him there. You tell him, look, you most likely require an ICD and I'm going to test it. And what is that test? What is the yield? Well, it's an expensive therapy. You'll have to get 5 lakh rupees worth of device. If he's not keen on that, well, you do not have to do anything further.
Let's get Dr. Prakash in for this.
So I think somebody, as Dr. Ullas said, somebody with in the background of a myocardial infarction, as very clearly there's a class 1 indication for implanting an ICD in cases LV function is less than 35%. Even if he's had, it's like a primary prevention. So that's very clear. And the MARIT 1 criteria, somebody who's undergoes an EP study and the VT is not suppressed by procainamide, again, carries a class 1 indication for an IC. That is one group of patients. Let me just bring in some of my patients who I have probably had problems with in the last couple of years. One young person, 45-year-old, Antrewal MI, revascularized, he was doing quite well. Ejection fraction was somewhere in the tube. His LV did not improve beyond 40 years. 40% was the LV function. He was not in the category for an AICD. He was not less than 35%, and he's never had any kind of syncope. One day, he just dropped dead. Just dropped dead, so 45-year-old in the prime. But one thing, yes, I knew that his LV had not improved, but he remained in that 40%. I couldn't even bring him down to say, okay, this fellow's got less than 35%, you implant an ICD. The least I could have probably done was maybe an extended loop recording or something like that to try and pick up a few of those arrhythmias, which could have probably occurred in him without any kind of symptoms. I'm telling you, I really don't know how to address this kind of a patient, which is, very hurting.
Yeah.
I feel I've let him down.
Yeah, actually, I just want to button here. In case you have, I'm just kind of opening up this point. In case you want to depend upon ejection fraction evaluation, should you be depending upon only echocardiogram in such a patient who has an anterior wall MI?
Yes.
And what is your take on that? Let Dr. Ullas also respond to this.
Yeah.
Go ahead.
Yeah. See, now, we all respect evidence-based medicine. And evidence-based medicine had been harmful in many instances. One of the examples is what Prakash quoted the example. He lost his patient because he stressed on the evidence base. That gentleman, he only told that if he would have monitored him further long, or if you had done something XYZ, his conscience is telling that he could have revived that patient, or he could have prevented that sudden death in him. But when it comes to the evidence-based medicine, we are talking about the treatment for a larger population. Evidence-based medicine is not for one single individual patient. We are talking about the cost effectiveness of that particular therapy. For that, we recruit the people and we randomize and we follow them up. So far, with whatever the limitation of the ejection fraction, there's nothing which is based on the evidence medicine, which is considered to be superior to the routinely measured ejection fraction, which is supposedly to be the marker of the risk for the sudden cardiac death. This exposes the limitation of the technology. This exposes the limitation in the larger context, the so-called evidence-based medicine.
Now, I wanted to check on this again, Dr. Ullas. In case your lab reports echocardiographic evaluation of EF as 45%, would you go ahead and evaluate ejection fraction by other means, or you would not like to?
Because you taught me to go by evidence-based medicine.
No, in the sense, would you like to order a kind of Muga scan, for instance, which is
what I'm trying to say is you are the proponent of the evidence-based medicine. Now, please tell me, where is this evidence? If your ejection fraction by echo is 40%, subject them to the Muga. If I send, you will be the first person to not to like me because I'm not following the evidence-based medicine.
Sure. Okay, let's get back to Dr. Prakash. What is his take on that?
So probably I would definitely I would not go just by, especially in this kind of a patient, which I had, I was just quoting. Ejection fraction is about 40%. He's in the border zone. And we know there is a scar there. Is that portion of the LV antral wall is not moving. So I would definitely try and look for some other investigative tool. I would go for a CMR. A CMR would tell me the extent of scar that is there. And we know that there is a scar there and this fellow is vulnerable for some kind of arrhythmia in the future. So I would probably start with that. And then, but again, as Dr. Ullas was saying, evidence-based medicine does not tell us that you can go and implant an ICD there just because there's an extensive scar. So I need some other way of trying to understand, but this man has susceptibility to arrhythmias, some kind of arrhythmias. So probably an ILR there, or some kind of investigative tool, or maybe, EP study would be a far-fetched one. If you're not able to induce, or even if you're able to induce, it becomes a kind of difficult situation to really fix him into. An ILR probably would help me in this situation, especially when the CMR is telling me there's a large scar there.
Okay.
And maybe we are underestimating the LVEF by echo.
Now, would you depend upon the scar quantification, or would you depend upon the ejection fraction?
Ejection fraction, sir. Again, ejection fraction.
Because
the guidelines say ejection fraction. It does not talk about the scar burden.
Sure, fair enough. Now, I have another question for you, both of you rather. A patient who comes with asymptomatic left bundle branch block, complete left bundle branch block, and he has mild left ventricular dysfunction by echocardiogram. How would you like to risk stratify for this patient for electrophysiological events? Dr. Prakash first, please.
Yes, sir, that's an excellent question. What is somebody who is in class 1 or class 2 and his LV function is in the range of 40 to 45? He has a left bundle branch block. He has all features of dyssynchrony, but we know he still does not qualify for any kind of device. Probably in this kind of a patient, I would just try medical treatment, optimize my GDMT, and then keep a watch on him. Tell him that probably time to come, you might worsen. In case you do, I would probably look at some kind of intervention in that situation. But at the present moment, with an ejection fraction, he still comes into the, depending on whether mid-ref or he's in the low ejection fraction, obviously he automatically goes into the indication for an for an CRT. But if he's still in the mid-range, obviously GDMT, and we have now wonderful heart failure medications, including the SGLT2 and all that. So probably institute that and keep a watch.
Now, how about in these patients, would you like to evaluate HV interval? Because you showed a couple of examples of HV interval being abnormal in a patient of left bundle branch block. I'm curious to know, in which situations you would like to order HV interval being measured?
Sir, HV interval would be useful in somebody. Yes, definitely it will be worthwhile doing it. But with a left bundle branch block, an additional, it's not going to help. I mean, as long as he has a prolonged HV interval, that's a different issue. But in the presence of a left bundle branch block, I don't think the advantage of looking at the HV interval would really add further to the prognostic evaluation.
If the patient has a syncope and left bundle branch block.
Pardon, sir?
If the patient has a syncope and left bundle branch block,
yes.
Would you like to evaluate HV interval or you would not like to?
So here, one thing we have noticed, I don't know what Dr. Ullas has to say. What I've noticed is when there's a left bundle branch block and a left axis deviation, we know that the entire left bundle is knocked out. And here, this patient, his AV conduction is depending only on a very thin right bundle, which is a very, very thin vesicle. Some reason we have noticed this. If transiently the right bundle conduction gets knocked out, he goes into a ventricular asystole, and that's had these problems in some patients. So in that kind of a situation, especially somebody is having syncopal attack, I would definitely look at the HV interval, and I would like to look at his susceptibility to this kind of a problem and how vulnerable is that right bundle.
Is it just a basal HV interval or the pacing induced HV interval response?
Just the plain HV interval.
You don't have to pace and then evaluate the response to pacing, does it?
Not necessary, sir. It can be done, but yeah, not necessary.
Okay. How about Dr. Ullas' opinion about it?
See, the left bundle branch block syncope, as long as the ejection fraction is normal, maybe you might think that it could be because of a bradyarrhythmia. But if you think left bundle branch block syncope and that is associated with a moderate LV dysfunction, you should remember that it could very well be a ventricular tachyarrhythmia. So in the lower ejection fraction left bundle branch block syncope, we should really work towards induction of the VT during the EP study. It does not end at measuring the HV interval, which is like baseline or stressed HV interval. That patient definitely has to go in for a VT study. So I'm clear there, I think. Left bundle branch block syncope, lower ejection fraction, VT is the common occurrence, and we should not miss, and we should not give just the pacemaker, or we just should not give just the CRT. I think we should be thinking about a CRT-D in that patient. Now it comes to relatively preserved ventricular function and an LVBB. With or without the baseline PR prolongation, with or without the slurring and the notches of the QRS, with or without the abnormality in the QRS, this gentleman requires an immediate EP study. Well, you do all that what you had done for a lower ejection fraction. But this guy, if it also has an easily inducible monomorphic VT, you have it. But most often, this gentleman would end up in having a CRTP. Or these days, well, conduction system pacing, if you think you can provide a so-called physiological QRS.
Oh, wonderful. In fact, I'm left with another 5 minutes of my time before I conclude. I don't find any questions in the chat box, and the organizer is also not showing any alarms. May I now request Dr. Prakash to give the closing remarks of his talk, and followed quickly by Dr. Ullas. Then I can make some concluding remarks about this topic. Dr. Prakash, please.
Yes, sir. Thank you. So to conclude, I think that's a very important session that we had today, primarily addressing a patient with transient loss of consciousness. And we understand that a lot of patients do come to us with these episodes of syncope, and trying to clearly tease out, categorize them into low risk versus moderate risk and high risk becomes an absolutely important step in trying to treat such patients. And in case we are able to do it right at the emergency level, so that they don't go and unnecessarily occupy hospital beds and go through unnecessary evaluation, if we can categorize them into the mild, moderate, or high risk, automatically we are able to do a lot better for these patients. And most importantly, by that ISL score, once we know that this patient has a cardiac syncope, this patient needs to be further evaluated and treated accordingly to prevent episodes of sudden death and disaster coming in the future. So that is probably would be my message in today's talk. And we also need to know that putting in a pacemaker unnecessarily for somebody with vasovagal syncope or neurally mediated syncope becomes, I think, an overkill. Unless the patient is an elderly and has been having really bad episodes of syncope, has had head injuries and so on and so forth, where you need to be aggressive in trying to put in a pacemaker. I think the most important thing is educating them, telling them this is a benign condition, not to really go in for an overkill, be it cardio inhibitory, and be it even hypersensitive carotid or a vasovagal syncope. Probably we should go in a very careful manner, educate them properly before we go in and implant a pacemaker, which many a times could be avoided.
Thank you, Dr. Ulas. Do you have anything to say?
Well, thank you very much. It is always learning when Prakash is around and when you are around. It was a great opportunity for me to be with you.
Oh, thank you so much, Dr. Ulas, Dr. Prakash. It was a wonderful session. In fact, I must put it on record that it was one of the great sessions I had been part of on syncope. And just to summarize just about 3 points, I would like to. Syncope is a complex, etiologically based symptom. So one should not be just kind of put it in a kind of basket of a syndrome as such. You should have some kind of underlying physiological parameter being examined by all of us. And that will be very helpful by head-to-toe examination, and also by evaluation non-invasively, and if necessary and very rarely with invasive methods of evaluation, because your decision will definitely will be as simple as a follow-up, as simple as with additional drugs, and as complex as the invasive investigations, and as complex as implanting a device with the lifelong follow-up with experts like Dr. Prakash and Dr. Ulas. Indeed, many a time, even with extensive investigations, it has been said that nearly 30 to 40% of the patients of syncope would not have a discernible cause, and they kind of remain undiagnosed despite several investigations. I'm sure both the faculty will agree with the statements I have made, especially with the ESC and ACC comparison statement being published just about a couple of years ago. Very important document for all of us to learn from. And indeed, the clinical practice and the clinical cases that Dr. Prakash shared with us are wonderful illustrations as to how complex the syndrome of syncope is. And I thank both the faculty for putting their efforts, and I thank the organizers on behalf of these two and on myself for providing this opportunity, a wonderful opportunity. Dr. Biradar should be congratulated and appreciated from all three of us. Thank you so much, Dr. Biradar. Thank you so much, all the eminent people on the dais here. Thank you and good night. Back to the.
Thank you, sir.
Back to the.
Thank you, sir. Dr. Antony, sir.
I think both the speakers gave a wonderful exponent of a complex subject like syncope, and I think we all go with a good knowledge about syncope. and probably will be able to help the patient.
Thank you, sir. Thank you. Lastly, I request Dr. D. Manjunath to propose the vote of thanks.
Okay. Thank you, sir. Thank you, everyone. Actually, I congratulate CSI Karnataka for conducting this virtual CME on World Health Day. We had an extensive discussion on syncope. We had how to identify high-risk features in a syncope patients. This was very, very important to pick up these cases. And we had a discussion on management of syncope in detail. So this will give us a lot of, for youngsters also to understand that syncope is just a manifestation, and then we need to pick up high risk cases so that we can manage them in a better manner. So coming to the vote of thanks, Honorable Chief Guest Dr. Vijay Bang sir, respected guest of honor today's Dr. P.S. Shankar sir, respected today's moderator Dr. Nagraj Desai sir and Dr. Ullas Pandarangi sir, our organizing committee Dr. Vivekanand sir, Dr. Ramurthy Bingi sir and Dr. Sangram Biradar sir, and our delegates. It is privileged to be asked to deliver the vote of thanks on this occasion. On behalf of CSI Karnataka and organizing committee, I thank all the speakers and chairpersons for taking the time to present this discussion on syncope and giving their expertise with audience today. I thank Dr. Vijay Bang sir and P.S. Shankar sir for gracing our conference with their presence and insightful words in the keynote address. I must mention our deep sense of appreciation for today's speaker, Dr. V.S. Prakash sir, for extensive deliberation on syncope and practical points regarding the management of syncope. Thank you, everyone. I again give this thing to Dr. Sangram Biradar sir to closing the ceremony.
I once again thank Dr. V.S. Prakash sir for accepting our invitation in this short notice to deliver a wonderful talk, and also Dr. Ullas Pandarangi and Dr. Nagraj Desai to be the moderator of this session. Thank you one and all. Before we sign out, I thank once again everybody, and I thank all the attendees who have joined for this program. Thank you one and all. Good night.
Thank you, sir. Thank you. Thank you.